Hello, I'm Dr. Novi, Dr. TCT Novy. People usually call me Novi. I'm an interventional physiatrist from Bandung, Indonesia. I worked in Adventist Hospital, Bandung.
My name is Dr. Shiv Kumar Singh. I'm a consultant anesthetist and I work at the Royal Liverpool University Hospitals. My specialization is mainly in ultrasound guided nerve blocks. I have graduated from doing nerve blocks as a landmark technique to PNS and now ultrasound. Most of my blocks are done under ultrasound.
That's great.
Yeah, I also actually teach on the chronic pain courses about prevention of chronic pain, especially related to the surgical persistent post-surgical pain.
Oh, well, I give lectures also, but for chronic pain, especially using ultrasound and fluoroscope. Yeah.
So I think it'll be a good idea to actually talk about use of ultrasound in acute and chronic pain.
Okay.
And we can go from there.
Okay.
So what we can do is talk about use of ultrasound in acute pain and how we can manage acute pain and get a better outcomes.
Yeah.
So nerve blocks have been used by anesthetists for a very long time. And like I said, we have graduated from landmark techniques where we just flooded the area with local anesthetic and hoped that local anesthetic will reach the nerves. Then we went to nerve stimulation using current to look at the response, motor response, and then put local anesthetic. And now we got even better because we can actually see the structures.
Yeah.
And we can use lesser volume of local anesthetic and be very, very specific with pain management.
Yeah.
So what we actually do is that we, in UK, unlike in some other places like Europe or the US, where they do nerve blocks awake, we tend to do them under general anesthesia.
Yeah.
So we give general anesthesia to the patient and then do a specific nerve block for the procedure, and followed by multimodal analgesia, which normally includes dexamethasone at induction, and then some non-steroidals if there is no contraindication, and then give IV paracetamol. And we've seen that we do something called opiate-free anesthesia, especially for limb procedures, for orthopedic procedures. We do not use any opiates at all.
Oh, that's great then.
Because we do not use opiates, so we don't have any of the side effect of opiates.
Yeah.
So patients don't have nausea and vomiting. Okay, patients wake up absolutely clear-headed, and we can discharge them earlier.
Yeah, that's great.
And the same thing of the multimodal analgesia is followed up in the recovery phase. And because you don't need any opioids most of the time, they are up and about. They can sit out. Okay, they can start walking. The effect of the analgesia also has been seen if you give dexamethasone intravenous, then the analgesia duration actually increases to almost 14 to 18 hours.
Yeah, that's great.
Yeah. And so most important thing is that we have to tell the patients that even if you don't have pain because they have nerve block, they still need to take their painkillers. And if they do, then they do not require any strong opiates at all. We do prescribe them opioids, that is if they are not able to tolerate the pain, but even then that requirement is much less. Also is something like I was talking about prevention of persistent post-surgical pain, and it has been seen that if you actually take care of the pain before the insult occurs. So we give blocks before the surgery starts, and that means that the nerves are already blocked, the sensation doesn't reach the spinal cord, there's no chemical changes. So incidence of the persistent post-surgical pain is much less in these cases. So how do you use ultrasound in chronic pain?
Yeah, in chronic pain, especially in the daily practice where the musculoskeletal problems is 60 until 80% of the chronic pain problem. So ultrasound is the best choice because using ultrasound we can see the soft tissue, we can see the muscles, we can see the tendons, we can see the nerve, we can see the structures that cannot be seen using fluoroscope.
Absolutely.
Although in the old days, people think that fluoroscope is the best, but for the MSK, ultrasound is the best because the second, we can use the ultrasound as an additional supporting diagnostic tool if we are doubtful to our clinical diagnosis before we proceed with our interventional pain procedure. That's the second. And the third, of course, to do the interventional guiding procedure itself. So as your practice daily, I can put small amount only of the drugs needed there. Then it will be very straight to the point and will cure the patients. That's in chronic pain. So fluoroscope still be used, especially for the spine problems, but for the MSK and nerve, ultrasound is a must if we want to do pain practice. Of course, we must learn relearn, reminding about the anatomy because we need the anatomy to do the ultrasound and read what is there in the ultrasound. Of course, if we want to do the diagnosis, maybe we cannot do it quickly, but to put the needle where I want to put the needle, that's the most important part, of course. We just need the sonotomy. We get the sharp clinical diagnosis and then we put the needle there and that's all.
And don't you think that because you're combining ultrasound with x-rays, you can also reduce the radiation as well?
Yeah, of
Especially
course.
like female patients, I think we are very worried about in that age group, childbearing age group. So you can actually reduce the radiation exposure as well in those patients with ultrasound. So I think combining the two modalities actually is very good. Even if you are doing a spine procedure, you can still combine it because I work with the spine guys, and when they're doing injection, that's what I do for them. Actually, I say, let me actually mark the thing for you, and I can put the needle for you. You can obviously fine tune it, so you can reduce the radiation.
The radiation, of course, But for MSK, we don't need fluoroscope.
You don't need absolutely. Yes, you can do the whole procedure.
But for the spine, we need to confirm that the drug isn't get into the vessel by using contrast. And then we proceed with the ultrasound. Just one shot is enough.
That's I think is one of the drawbacks of ultrasound is that yes, you can see the local anesthetic. There are contrast actually available, but they are not freely available for ultrasound. But we can't actually store and give away because there's also medical legal aspect as well, where you can take an X-ray and show that we did actually inject it in the right place. With ultrasound, it may not be possible. So that is one of the things.
So for acute and chronic pain, ultrasound is one of the tools that is a must to do the interventional pain management besides of the fluoroscope.
Absolutely. Do you use any nerve stimulation as well? Because in acute pain, some people like to use combination of the nerve stimulation along with ultrasound. Do you use that in chronic pain as well?
Actually, if we use ultrasound, we've already see the nerve. So we don't need to use the stimulator. Except if we are doubtful, where is the nerve, where is the nerve? We combine it with the nerve stimulator. But if we already see the nerve, no need stimulator anymore.
I mean, one of the other things which we actually see in chronic pain as well, and which I have actually noticed while reading about prevention of chronic pain, is the psychological build of the patient.
Yeah.
We know that chronic pain causes psychological problems because it is known to cause depression. But what I actually looked at was it is seen that patients who actually already have any kind of psychological problems, especially depression, and these patients are prone to develop chronic pain or persistent post-surgical pain. So I think managing that aspect is also very important. And when we actually speak to the patient and explain to them that you can actually have a surgery where you would actually wake up with almost no pain, or the pain, if it is there, it can be easily controlled. I think that psychological build-up is actually very, very important.
That's great, Before it goes to become a chronic pain that is more difficult to treat.
Yes. And the other thing was that it is actually seen that with females again, the post-surgical pain is actually more common in females. So we're now insisting that patients who actually especially like breast surgery, there are newer blocks. I mean, people have been doing thoracic parietal blocks for breast surgeries. There are now less invasive ones like PEG blocks. So those are actually, I think, making a lot of difference in the outcomes of the patient as well.
The outcome is good, right?
Yes, absolutely. I think patients wake up pain-free. Again, opioids have been seen. They actually causes depression of immunity. Okay, and there is now a lot of studies where showing that maybe patients who were managed only with opioids for pain, the chance of recurrence is much higher compared to patients who actually had a combination of regional anesthesia. So there are a lot more studies going on in those kind of aspects as well. So I think regional anesthesia has got a lot to do with prevention of chronic pain, prevention of cancer recurrence, and obviously outcomes as well. Patient getting discharged early. So the cost for patients, especially because I work in the National Health Scheme, where everything is paid by the taxpayers. So if you reduce the cost, the stay in the hospital, then the cost is reduced as well.
Talking about the cancer pain, we can do the celiac block, hypogastric block, using ultrasound from the anterior approach.
Yes, that's right.
Cheaper compared to the fluoroscope.
Yes, absolutely.
Okay.
I think,
maybe
thank you.
That's all. Thank you very much.
To stay updated on our latest KOL videos and interviews, please follow us on Twitter, like us on our Facebook page, and subscribe to our YouTube channel. Happy Docplexing!